I'm Anne. I'm a Regional Support Development Manager for Prescribing Support Services and Optimed.
And my name is Eleanor Barnes. I'm the Lead Clinical Pharmacist for Prescribing Support Services and Optimed.
So as Damien said, we're just going to talk you through about how you can make the most of your pharmacist workforce within your PCN. So just a little bit around Prescribing Support Services. We're a national medicines management service provider. We currently work with over 300 practices across England, and we do a range of services. This varies from in-practice and pharmacist support. We also have a hub based in Bradford where we work remotely with practices across the country. So our pharmacists work from there and dial in remotely to complete their workloads. We also offer a mesh service, which is medicine reviews at home, an anticoagulant service, and then also in our sister company Optimed, we do medicines optimization. So there is a wealth of experience here at the table, because Eleanor's been with PSS I think over 10 years, around how to make the most of a pharmacist service in general practice and primary care. So in terms of the PCN pharmacist, in your newly formed PCNs, you've been granted funding for a PCN clinical pharmacist. So this is 70% funding for one whole-time equivalent pharmacist, and that's been available to PCNs from the 1st of July. Now that 70% is 70% of 55,000. So the maximum reimbursement that PCNs can look to receive is about 38,000. And that means that the PCNs would then have to put in themselves around 16,000 up to the 55,000 mark. Now this can be for one whole-time equivalent pharmacist, or if you wish, you could make that into 2 part-time pharmacists, so they would have to work at least 0.5 of the hours, so at least 18.75, and you can make up the pharmacist in that way. In terms of the requirements to be able to be eligible for this funding, and they say that the post needs to be clinical and patient-facing in nature, and that pharmacists must receive support and supervision to allow them to do their job safely and competently. I'm now going to hand over to Eleanor, who's going to talk about the role of the pharmacist within the PCN and how you can make best use of them.
Thank you, Anne. So, what can you expect the pharmacist to do? So the time that they will spend on site, essentially, they'll be there full time with you, and they can be doing a variety of different jobs. Now, where they will add value to your practice or your PCN, they can be doing high-risk monitoring. They can be looking at auditing those monitoring systems, so making sure that the systems that you've already got in place are working well and working safely. And are they capturing all of the patients that need to have their that are on high-risk drugs? And are they getting the correct monitoring at the right frequency? They can be doing medication reviews, and they can be done in clinic or over the phone. So the medication reviews that they can do, they can be a general medication review, so whatever's due to come up in the next month, or you might want them to target a particular disease area. So if you've got a heavy practice nurse heavy practice nurse component in your practice team, they may already be doing asthma reviews, they may be doing diabetes reviews, etc. So what you may wish to do is ask a pharmacist to look at patients that aren't being captured by those chronic disease reviews. So maybe patients who are using regular opioids, maybe patients who are on shared care drugs. So things that aren't captured by the usual practice nurse chronic disease reviews. Or of course the pharmacist can also do their chronic disease reviews to mirror the nurse's reviews, but looking at other aspects of the medicines monitoring and medication taking.
Sorry to interrupt, Eleanor. Just before,
yeah.
Is there anything interfering with your microphone at all? The sound's not brilliant, that's all.
Oh, I'm not sure.
You seem okay, or?
Is that any better?
Hopefully. That sounded better immediately. Sorry to stop.
Sorry about that, guys. So other things that the pharmacist can do, they can help with medicines reconciliation. So that would be reconciling the drugs when you've got clinic letters coming through the system or when you've got discharge notes. Now, they can be looking at patients who are high risk, or they could be looking at those discharge letters or clinic letters that are high risk in themselves. So these may be where a patient has had a complex admission, has the patient had an extended admission, a long stay. Maybe the discharge note is particularly complex or it's inaccurate. There's lots of drug changes, it's not very clear. That might be something that you want your pharmacist to look at. The patients themselves might have high social needs. Do they have memory problems? Do they have issues with accessing their medication? Have they got carers? That kind of thing. And all of those elements will affect their medicines management, how they take the medicines. So we can advise on ways to ease that burden and to help patients make the most of their medicines. And of course, we can be looking at patients who are on your traditional high-risk drugs. And of course, the pharmacist can also help with dealing with acute medication requests. So where a prescription is not on repeat, patients obviously are asking for those medications and they will often go through the GP. This is where a pharmacist can have some real input into making sure that those medicines, if they're appropriate, can go on repeat so the patient can continue to access them. Or they can do a risk management for each drug for each issue and come up with an action plan for a follow-up plan for each prescription. So, competency of your pharmacist. So your competency of each pharmacist is different. We are all different. We all have different backgrounds, different historical training. A pharmacist from a community background will have a very different need for training than a pharmacist from a hospital or another more clinically focused background. So your pharmacist, whether if they are from community, whether they are independent prescribers or not, they are likely to have higher training needs than somebody with a more clinical background. And now that's a sweeping generalisation. I'm probably doing my community colleagues a service, but just to give you a general idea of what you can expect when you are looking for a pharmacist and what background they might have. And then, of course, your pharmacist will be looking at your clinical priorities, whether those are local or the direct enhanced service areas. And you might also want to think about what are your practice priorities. So what is your workflow like? What are the demands on the system? Where are the pressure points? And can a pharmacist impact on those and influence those? Maybe looking at making the workflow more efficient or simply slotting in to help redirect some of that work. Now, it's really important to note that whilst the PCN funding is funding a pharmacist who is patient-facing, this patient-facing element has been interpreted differently by different CCGs and different PCNs. So it's really important that you know what your CCG deems to be patient-facing. We have got cases where CCGs are happy to say that a patient-facing pharmacist is somebody who's looking at a specific patient's record, so they are reviewing one specific patient. They are not doing a general audit. Whereas others have said, no, the patient has to be sat in front of the pharmacist for it to be patient-facing. Again, like the slide says, depending on the experience and the clinical competence, it's really, really valuable to know that your pharmacist may not be ready to deliver a patient-facing role on day one. They may not be ready to do patient-facing clinics. Now, hopefully they will be, and you might be one of the lucky ones that lands a pharmacist that is ready to hit the ground running. But it's good to ensure that your expectations are realistic and that you understand where your pharmacist has come from, what background they have to deliver the kind of role that you want them to deliver. Okay.
So just following on from what Eleanor's just said there, I think the idea around this whole clinical pharmacist and PCN has come at a time where it's a big change for pharmacy at this moment in time. It's quite an exciting time. But there are a lot of pharmacists out there who work in typically like community who are crying out really for a more clinical role, and they're really excited about these PCN clinical pharmacist roles that are out there. We've also got a lot of community pharmacists that have gone out as self-funded, getting an independent prescribing qualification, but are not able to use it in the community pharmacy setting. So you may find that if you go out to advertise and you're looking for pharmacists, like Eleanor said, there'll be a range of pharmacists with all different experiences that will come to you. And I suppose part of that then will be to manage your expectation of what you actually want to gain from that pharmacist. And like Eleanor said, they won't necessarily be ready on day one, but it's a journey for them, and they'll go through this journey and they'll start off sort of early doors and be able to do one level, and they'll grow into the role, and that's how we see it. Obviously, with the funding, that can increase after April next year, and the idea is that, you know, into year 5, you may be looking at about 5 pharmacists per PCN, and the pharmacist that's been with you from the beginning would probably lend themselves into a lead supervisory role with those pharmacists as your new ones come through, so it's something to bear in mind. Obviously, with experience and the expectation of the role comes the salary, which is also something that the PCN needs to consider. So the funding does only cover, like we said, 70% of the funding, which equivalents to 38,000. But you've got to then consider your own costs on top of that. So if you're employing directly, you'll be looking at NHS T's and C's and the on costs with that. So in terms of pensions, can be slightly more. If you're looking to go with a service provider, obviously there will be on costs associated for them, so that they would be charging you sort of an overall service management fee. So in terms of our experience of what we've seen for pharmacists through PCNs, as you can see on the slide on there, we've got kind of just a baseline, so just a rough guide of the kind of salaries that pharmacists would expect in line of what you can expect from your pharmacist. So we've kind of loosely banded them band 7, band 8A and 8B. So in terms of the band 7, if you look at the salaries there, starting from around 37 for someone with probably little or no general practice experience, probably only a few years of community experience, and then going up to 41.5, and that fits comfortably within the funding, because if you're looking at a funding of 55,000, if you consider your on costs, salary wise, you're probably looking at about 42,000 in terms of salary. So that's probably what you can expect to fit within that. If your PCN wants more from their pharmacist, has a greater clinical need, and kind of wants to start sort of higher up in that journey for that pharmacist, they can obviously contribute more towards that funding. They don't have to stick within that 55,000. You know, you can put in as much as you want if you've got the right kind of pharmacist that you feel is going to work for your PCN. So then you're looking sort of at the band 8A and 8B, which we've loosely termed around about 43 up to 47.5, and then for an 8B, you're looking at, you know, a very experienced pharmacist who probably is able to sit down and do your patient-facing clinics from day one, and their costs associated with that. Again, if you're looking at another service provider, their service fees will also increase in terms of what they're going to provide you from their pharmacist, and so that's also something you might want to consider.
So the PCN pharmacist role is a training role. All pharmacists that come into a PCN role, they are automatically enrolled onto the Health Education England supported training programme. This programme lasts for 18 months, which includes the IP qualification module, which is a 6-month module. So if your pharmacist is already an IP, then they wouldn't have to do that module, and so the training programme would be a 12-month duration training programme. And the aim of this is to ensure that our workforce is meets the baseline. So wherever they've come from, irrespective of what their experience is, they will, by the end of the 18-month programme, they will all be working at the same level. And then part of the training, of course, is the IP training. And so there is some GP tutor support element to help with the IP training. Now, the most common question that we get asked for from PCNs is how much time do my GPs need to put into this individual and into mentoring them? And we've sort of broken it down. Of course, the mentoring needs will be higher at the beginning, and obviously they will tail off, particularly once you get towards the end of year 5. But we reckon that on average, you can be expecting to spend about 30 minutes a week with your pharmacist to go through, to do a bit of a clinical debrief of what's happened during the week. So those sort of specific clinical questions, circumstances that they're not too sure of, where they need a bit more support, a bit more guidance. That's what we reckon that you'll need to give them on average per week over the years. Okay.
There are some other considerations you'll probably want to make when you're deciding around employing a clinical pharmacist in your PCN. So your options are obviously to employ directly, and we spoke a little bit around the costs in terms of doing that. And the other option is to go with a service provider who will provide a pharmacy to you and manage that service. I suppose the considerations you'd need to make is the level of training and support this pharmacist would require, and do you have the expertise and experience within your PCN to be able to provide this? So there are some PCNs out there who have got quite established pharmacists already working within their practices, and those pharmacists could sort of provide that supervision for a new pharmacist coming in, and they'll have a clear idea of their expectations, the work that would like to be carried out, some training around how this work can be carried out, and that's fantastic. There'll be other PCNs out there that potentially haven't had much experience with working with pharmacists and knowing how to utilise their pharmacists. We have found in our experience the experience for GPs out there is really varied. Some GPs think pharmacists are fantastic, they can see the value, they can see the pressure being taken off them with the work that the pharmacist picks up. Not everyone has had such a positive experience, unfortunately. And I think there are some practices out there who struggle to see the value in their pharmacists. That's usually because they just haven't utilised them in the right way and given them the clear defined expectations of what work they want covered and what picked up, and understanding the limitations but also the competency of that pharmacist, because there are a lot of things out there that pharmacists are able to do and tasks they're able to carry out even without being independent prescribers. There's a whole host of work which can be done to ease the pressure of GP workload. So that's something to consider. Does your PCN have that expertise and the knowledge to be able to make the best use of their pharmacist? And if not, like I said, there are service providers out there who can provide that. For instance, we would support with any training, mentoring, supervision, and service providers can often tell you what kind of tasks the pharmacist can pick up and support you with that and support the development of the role. So that's something to consider. The other aspect to consider is all your HR obligations that come with employing directly with an individual. So you'll have to think about, obviously, any sickness, maternity, any absences, they would be covered by yourselves and at a cost to yourselves. Any HR like appraisals, disciplinaries, any issues that way, performance management, you would have to be prepared to be able to pick up and understand enough about the role to be able to pick that up. Again, like I said, there are service providers out there who will do that for you. So for instance, in the managed service like we provide, we would take care of all of the HR aspect, right from recruitment to induction, training, any disciplinaries or HR issues that arise, appraisals. We'd also cover sick pay, maternity, sick maternity and any absences like that. So that's just a consideration that the PCN would have to make. And I think there's a big piece there around when you're kind of setting your expectations for pharmacists. Like I said, it's a turning point for pharmacy at this moment in time. It's to make the role really engaging. There's a lot of pharmacists out there who might be mistaken in thinking that it can become quite an admin task in general practice. That's fair to say, Eleanor?
Yeah.
And we kind of want to steer away from that because, like I said, you want to make the most of your pharmacists and the most of their time. So it's just ensuring that it becomes kind of a varied role for them to be able to sink the teeth into, and that way you'll find that they'll stay with you longer and you won't get that kind of pharmacist turnover that some practices sometimes see if it's a very heavily admin task. The other consideration is peer support. So does your pharmacist have other pharmacists within the PCN or locally that they can communicate with and go to if they have any queries or questions or just some general support? So that's also a consideration you might want to make, is that available to your pharmacists that are coming in? If it's not, is there any way that you can make that available? Or again, like I said, with service providers, that generally is because they'll employ a high level of pharmacists, so they'll find a way to get that peer support and for your pharmacists coming in. So we did talk about sort of absences and cover. Obviously, if your pharmacist is off, if you decide to employ directly, then they're off and you'll have to manage that workload elsewhere within your practice. There are certain providers like ourselves where we can provide a hub service to either complement or to cover your pharmacist should there be any absences. Like I said, any long-term absences would be covered by a service provider, so you would hopefully get like-for-like pharmacist in their place. There's also that small issue of sometimes you'll employ a pharmacist or you'll be provided with a pharmacist and they're not a good fit for your PCN. And if you've employed directly, it becomes difficult to navigate away from that. Whereas if you go with a service provider, they will navigate through that for you and hopefully find a pharmacist with a good fit for your practice. Is there anything to add on that point?
I think so, no, I think we've covered it.
Yeah. Oh. Sorry, just having a technical issue there. So yeah, that really essentially is our quick guide to making the most of your pharmacist workforce. Hopefully it's giving you a bit of food for thought for some of the areas you need to consider and think about before taking on your pharmacist. Yeah.
I think that's it, isn't it? I think that it's an exciting time because the role is in its infancy and it has such potential. It's really exciting for us, and it's nice to see the pharmacy profession being utilised, using its skills as they should be used.
If there are any questions, Damien, I think we'll take those questions from you.
Thanks very much, I really appreciate that. Lots of juicy tidbits in a very short space of time, so really good, thank you. We've got one question, I'll ask that in a second, but I'll just remind everybody that they can ask questions through the Q&A and the chat facility. So the first question is, one of our attendees, PCN, is made up of 4 practices. So how do you guys see a single clinical pharmacist potentially working across the practices in the first 6 months?
So we've had varied approaches to this, and we normally work with the PCN in terms of what their greatest needs are. What the PCN tend to go with is looking at patient list size, and they'll distribute those hours accordingly according to list size. So, you know, a practice with the largest list size will get the largest chunk of the hours, and so forth as you go down. It doesn't have to be that way. Some PCNs want to just split the time equally between the practices, which is fine as well. So we've worked towards that. But I think, Eleanor, what would you say is the best way?
Yeah, I mean, I would probably suggest that going with the first approach is to looking at your patient list size. I mean, essentially, a pharmacist is going to be looking at individual patients, so you want to make sure that their time is being used in the most equitable way. So looking at patient list size, divvying the time up like that, and then looking for on each individual practice level, looking at what the workload pressures are there. So where do they need specific help? And the role between the practices may be very, very different, but it's about how those practices use that time to the best effect for ensuring that patients are being cared for well.
You'll just have to consider the geography of your practices and how far or near they are and the travel time between those practices. And is there some remote work actually that could be done from one of your large practices or one of the smaller that would still constitute your patient-facing work? So there's some considerations you can make. In terms of the pharmacist first coming in, some PCNs like to have the pharmacist just working at one site initially first, getting to know how that PCN works in that particular practice, and then going out to the member practices after they've had about 4 weeks or so in the first practice. And what this does is it just allows the practice and the service that they get from the pharmacist to be aligned between and to be consistent. That's it. So it just allows for consistency across the PCN in terms of service.
Great, thank you. Thanks, Ams. Thanks, Eleanor. We have another question as well. Do you have any ideas for bringing income into the PCN to cover the 30% cost element, which is down to us to make the sort of cost neutral rather than become a cost to the GP partners? The question. Example, so outsourcing for CCG community work, for example, or out of hours or hospital work.
So ways to increase the income into the practice. Now, one of the projects that I've been involved in the past in some of my previous practices has been looking at where practices are administering drugs within the practice, are they buying wisely? Are they buying in a savvy manner? And the way, I mean, looking very much on how a community pharmacy works as well. Are you getting the best profit margin for those particular drugs? A lot of them can be bought in bulk, and so you can get them at discount prices, and that means that the return that you'll get when you submit the prescriptions will be a lot higher than if you were buying them individually. And also, are you submitting your prescriptions in the best way to get the most back from those prescriptions? And that's something that it's bread and butter for pharmacists, particularly the community pharmacists. And that's where they will come into their own. They will help you to increase that income to maybe offset the cost of them being in practice.
Thanks, Eleanor. Thank you. Answers the question. Got 3 or 4 minutes left for attendees, and I know you're still all logged on, so that's great. If you do have any questions, do fire away quickly if you can type fast. But myself, Ams, and Eleanor will be here for a couple more minutes, so do feel free. While you're considering that, it's worth mentioning that the slides for this presentation and a recording of this webinar will be going on to the Primary Care Direct website, and we'll check that with everybody who's registered. I can't think of anything else to mention at this stage. Anything from yourself, Ams or Eleanor?
No, I don't think so.
Okay, that's great. I guess we'll just hang around just in case anybody's got any more questions. We've told everybody we'll be here till 12:30, so hopefully nobody's rushing off to lunch.
It's the only thing I can think of that we didn't talk about was sort of liability, which is often a question we get asked. So if you go with a service provider, they'll normally have their own liability insurance. So we have our own for our employees, and they would be covered to work in your practice. If you are looking to take on pharmacists directly, you'll have to ensure that your liability insurance does actually cover that pharmacist, particularly if they become IPs. So that's something you do really need to think about and ensure is in place before you go and recruit your pharmacist, particularly like I said with the IPs, because there's more of a risk there.
I think also thinking about IPs, it's quite a common misconception that as pharmacist prescribers we can sign off your batch sign your repeats. Unfortunately, we can't. We can only sign any prescription that we have clinically checked ourselves. So whilst we can absolutely do sign prescriptions when we have done a medication review, if we've decided that that acute request is a valid request and it's safe and it's appropriate, then we can sign those prescriptions. But unfortunately, we can't sign those prescriptions that are generated by the admin staff from the repeat requests.
Okay, that's great. Another question. Have you already clinical pharmacists lined up to start in January 2020? Are you on top of this?
Well, we do have, for all of our PCN customers that are currently with us, we have recruited or in place. Obviously, that's a changing picture every day. We've got a flurry of PCNs at the moment interested in our services because obviously it's coming to that time of the year and everybody wants to get them in before April. And lead time, depending on geography, it can be anywhere between sort of a couple of weeks in, say, like West Yorkshire, where we've got a strong hold of pharmacists, up to maybe 12 weeks in other areas, because there are pharmacists that have to give usually a minimum of a 12-week period. That's something to consider. But yeah, we're doing okay in terms of getting our pharmacists ready for January.
Good, that's good. That's good. Any more questions? Nothing's come in just yet. You've got maybe 30 seconds, people, if you do have anything that's pressing. If not, feel free to leave a note now and I can communicate I can send the questions over to Ams and Eleanor afterwards, and I'm sure they'll be happy to email those. Yeah, I make that 12:30 just gone. So if we conclude that there, I'll leave this open for the next 10 minutes. So if you do have any questions, do leave them, but I'll let Ams and Eleanor go for now. Let them enjoy their lunch. Thanks very much, guys.
Okay.
Thank you.
Thank you very much. Thank you. Bye.
Bye. or anybody who's still logged on, I'll log off now. I don't think there are any more questions coming through, but you do have all our contact details, and we'll share these slides over email. Thank you for joining us, and hopefully you'll join us for the next Primary Care Direct webinar. Thank you.